So thank you all for coming. I am really impressed with the turnout and the interest, and I feel like this is really a great sign in our field that so many people are thinking about this topic. So I will fully admit that one, I am not an expert in compassion fatigue and burnout. I'm not a psychologist, I'm not a social worker, but I want to try and make the case that we all have a role to play and we can all affect change in our own environments. All right, so first, just to define the problem that we're dealing with, I have some data that I pulled from 2 studies that were published in JAVMA. I think probably everyone in the room is familiar to some degree with these studies. Looking at mental health issues in veterinary medicine, it's pretty well known that veterinarians are at higher risk for suicide than other professions. 1 out of 6 veterinarians that were surveyed in one of these studies contemplated suicide at some point after graduation from veterinary school. Mental health issues are very common. 1 out of 10 female veterinarians that were surveyed reported that they were experiencing serious psychological distress at the time that that survey was circulated. So if you think about 10% of us out there are currently really struggling. So the 2 big issues that have been really identified and explored are compassion fatigue and burnout. And they're 2 different concepts, 2 different problems that we face in our field. And they are very different manifestations of the effects of very similar stressors. So compassion fatigue really results from the secondary trauma, from the patients that we see and the situations that we confront on a daily basis. We are just constantly exposed to situations where we're taking on a huge emotional burden from the clients that we consult with. The emotional burden of our interaction with our patient and how we feel about the decisions that get made, and our role that we play in making those decisions. Moral stress is a huge problem in our field. What I'm learning as I've had more interactions with human MD professionals who are kind of grappling with these same kind of issues, the moral stress issue in veterinary medicine really seems to be a whole lot more intense. The financial piece of veterinary medicine puts us in the role of having to recommend things that we don't necessarily want to recommend, of not being able to provide the care that we know we can and that we would like to. We sometimes have clients who make decisions about continuing care when we feel like that's unethical. But we don't hold the ability to make that choice, but we hold the responsibility for kind of carrying that emotional weight. So compassion fatigue is something that's very hard to recover from. And if you've ever seen someone who's been through this, it's really devastating. These are generally people who leave the field, who leave their profession. And it's just a tragedy for us to have that kind of loss from our field. So the people who are the feelers, who undergo this transformation into a compassion fatigued person, really lose that connection in all aspects of their life, but especially in their professional life. Burnout is a little bit more straightforward in that this is something that occurs because of our work environment. So exhaustion, I think, is probably rampant in veterinary medicine. If I took a poll out there, I bet a lot of you are propped up with some coffee right now. Burnout can manifest itself in cynicism and detachment. So I think a lot of people are used to having kind of a gallows sense of humor, and that can be a healthy thing, but it can also be, a sign that maybe you're losing that touch with what brought you to veterinary medicine in the first place, and the connection that you should be enriched by with your patients and clients. And feelings of ineffectiveness. So when we have barriers to us doing what we do best, that can lead to burnout. It's just that constant frustration, whether it's something as silly as In human medicine, the electronic medical record is considered to be a big driver of burnout. The fact that you have to click 25 times before your patient can receive a medication. That type of thing can actually lead to burnout. So for us, I think we probably have a million frustrations like that, not just limited to medical records. So the contributors to both burnout and compassion fatigue are isolation, stress, moral distress, excessive demands, which in our field, we are such a driven group of people that when we think about the demands that are placed on us, I think in general, the veterinary industry is pretty tough on the participants. Expectations are high that you're going to commit a lot of time and a lot of energy to your job. But I think the internal demands and internal expectations that we have of ourselves are probably even more than those external demands. So the expectation that we are always going to show up at 100% and we are going to do right by our clients every day, that's of course a normal expectation, but the expectation to be perfect every day and to not need any support, that's not something that's sustainable. And then in our field, we are constantly exposed to death and other emotionally charged situations, but I was recently at a conference with other human practitioners talking about support groups. And when I talked about what our day-to-day life was like, the idea that we saw multiple deaths in a day was shocking to them. So the idea that we are constantly interacting with end of life, that's a very stressful thing. So I'm going to try to have everybody participate in this, and I want to kind of talk through some of the scope of the problem that we might see in ourselves. So on each of your tables, there's some instructions for texting in, or if you have good eyes, you can read right on the screen. So this is an interactive poll. If you text that Shayna O'Mara 960 to 2233, it'll let you join into the system. And then there's going to be a series of questions that I'm going to ask you guys to weigh in on. It is totally anonymous. I don't have access to your phone numbers, so if I can ask you guys all to whip out your cell phones if you've got them, and I'll give you a couple of minutes to get situated. And if you can rank your agreement with the statement, I feel emotionally drained from my work. And there's frequency there with A being never and G being every day. And that should update live for us. Okay, so I think what we're seeing here is that we have a relatively high frequency of feeling emotionally drained from our work. So if you think about how we take that home with us, does that mean that we have the emotional availability that we want to for our family and friends and community outside of work? So moving on to the next question, which is the same type of question. So just rank your agreement with the statement, working with people directly puts too much stress on me. Somebody feel strongly, very quick. All right, and so we've got a nice bimodal distribution there. So it seems like we've got some people who are maybe charged by interaction with other people, some people who are feeling stressed out by the constant human interaction. And then I've got one more for you. So can you rank your agreement with the statement, I feel used up at the end of my day of work? All right, so it seems like we have a pretty high frequency of people who feel like they're just used up. Their tank is empty at the end of the day. These last three questions are actually questions that I lifted out of the Maslach burnout inventory. So this is a psychological test, an instrument to measure the level of burnout. So this is a random selection of three questions. This is not scientific. But I felt like these were kind of illustrative questions to give you an idea of kind of the flavor of what burnout might actually feel like. If these questions really resonated with you as, yes, oh my God, I feel this strongly, that might be signs that you might be struggling with some burnout. Oh, go ahead. That is a great question. We have no idea what normal is in veterinary medicine. So there are some studies out there for different professional groups, but there's not a normal for veterinary medicine, and I think it's a very revealing question, because when I think about giving this test to veterinarians and veterinary professionals, I kind of expect to have a pretty high number for our burnout, or a high measure of burnout. And I think that expectation is pretty revealing. I think we all know that we work incredibly hard and that our work is very taxing. So I apologize for experimenting on you guys, but I wanted to try and give you guys a little bit of an idea of everybody in this room has some degree of stress over what they do for a living. All right, so this next one is going to be something where I'd like you guys to answer the question, how do you feel when a case goes poorly? And if you can just type in either a word, or if it's multiple words, just put in a dash or a period instead of a space. And if you guys can, it'll be the exact same text, so you can just keep on with the string. And we're going to have a word cloud show up here that'll update live. I am not trying to bring you guys down, I promise. Okay, so what I'm seeing here, I think, is common feelings that we all are going to feel when something doesn't go well. So, of course, we're sad and disappointed when one of our cases ends poorly. What I was really curious to see is what kind of language we use to describe our feelings when we're dealing with a patient whose course has gone poorly. So in here, there's defeated, frustrated, disappointed. Those are, I think, all very, very resonant feelings that I think we've all experienced. What I was curious about are words like stupid, failure, responsible. These are all very judgmental words, they kind of express a shame and a guilt that really isn't ours to own. So there's a lot of emotion that we assign to ourselves, where we feel responsible for everything that goes poorly. It's a personal failure, rather than acknowledging that some cases don't go perfectly, because sometimes illness is severe, sometimes death happens when we don't intend it to. And I think this is something that was really revealing to me in talking with human practitioners, palliative care practitioners, in working on Balint, which is a little hint. I'm gonna talk a lot about Balint towards the end. One of the things that really struck me is how much we try to control death and make it palatable. And that's for our clients, of course. We want them to have, our clients and our patients to have a good end of life experience. But we also feel like a failure when we lose a patient. For me, if I have a patient who dies, I feel a personal sense of failure that I haven't somehow anticipated that was going to happen and control it in a kinder way than a natural death. And that's not something that any other field really deals with. In human medicine, death is a reality. Death happens, and it's not our responsibility to control life and death. So I feel like that's another big stressor that was revealed to me. The other question I wanted to ask is who you talk to when you're processing a difficult case. So when you have that case go poorly and you feel like you need to talk to someone, who are you talking to? All right, so wingman, I like that. So as these answers turn up, I think it is really great to see how much of a support system a lot of us do have. And I think it's important to recognize when we're sharing these experiences with people, the experience that I'm going to have sharing my distress over a case with someone who is a practitioner who's in the veterinary field, they're probably going to have a different understanding of the situation compared to someone outside of the medical field, and that may be a good thing. One of the things to be cautious of is actually passing on the trauma that you've taken on to someone else. So, when you're talking with someone in the veterinary field, with a coworker, with your partner, your spouse, your friends, it's always a good idea to kind of check in with them before you share what's troubling you and make sure that they're ready to receive that. So when I think about sharing a troubling case with a coworker, there's a really good chance that they're also struggling with something, and that might be great. That might be a wonderful way for us to come together and help each other out. But it's always a good idea to just check in and say, like, I have something that's really troubling me. Are you in a place where I can share this with you? All right, and I think this is the last one, and then I'll take on the work again. So do you feel supported in your role as a veterinary professional? All right, so we've got a mixed bag, but a good number of yeses and mostly's, and that is fantastic to see. So what I'd like to see is for those not very much or rarely's to turn into the mostly's and the yeses. And I think the reason that I wanted to come up here and say, like, I'm not an expert. I saw the problem, you see the problem. We can all do something about it to affect culture change wherever we work. So if you're in a position of leadership and a position of power, that might mean that you can do something institutionally to support your community of people who work together. If you're in a position where you don't have that kind of pull or that kind of bandwidth to do, there are still things that you can do to kind of cultivate a culture of support between your coworkers. And absolutely feel free to take my message to your leadership and send them to me. One more question. So what resources are you aware of that offer support for veterinary professionals? Okay, so, I think Enid. So that's Enid Traceman. She's our social worker at Dove Lewis. For any of you who don't know her, she's been on a short-term leave. She's coming back this summer, and she's a great resource for everyone. So in here, we have a lot of people picking up on self-care that you can do to kind of look after yourself. A lot of people mentioning therapy and counseling. And I think over the past 5 years or so, we've really just seen an amazing change in kind of destigmatizing seeking care. So, we are in a field that has stresses like no other. It is not surprising that we might need a little extra support. So I think right now, I don't think anyone would ever bat an eye at someone seeking counseling for work-related stress in veterinary medicine. And that probably wasn't the case, 5-10 years ago. So we've made great progress. And there actually are quite a few resources out there to support veterinary professionals, especially in crisis. So these are just some resources that I was able to pull. So the Facebook answer was a good one. So Not One More Vet is a Facebook group, and this should be in your notes as well. It's a Facebook group that is a support group for veterinarians who are just experiencing distress. So it's not one more vet because the goal is to prevent any further veterinarians from committing suicide. They have a bad day phone list, which is literally a list of volunteers who give out their phone numbers for anyone who's having a bad day to call and just have a sympathetic ear on the other end. VIN has the Vets for Vets website, which is it's a messaging group and also provides some resources for reading. Mighty Vet has online courses and mentorship, so meant to kind of build the skills that are going to make you more resilient and more resistant to some of these stressors. The AVMA has a wellness initiative with a lot of articles and resources. And actually, I left off on here, AHA has also added on a really nice wellness section, along with some practice tools to help you kind of implement a culture of wellness in your hospital. And then there are some kind of urgency hotlines. So the National Suicide Prevention Lifeline has both a phone number and a text line. So a lot of people are hesitant to pick up the phone and talk to another person, but texting can sometimes be an easier thing to do. There's also the crisis text line. And the PVMA has a great list of resources as well. So they have a webpage that's health and well-being resources. There's the Metro Crisis Line, another kind of local kind of general support as well. So I wanted to give a little bit of background on how I got interested in the idea of professional groups and wellness in veterinary medicine. Back in my former position before I started at Dove Lewis, I led an ECC residency training program, and we had a particularly challenging case that really brought into focus the difficulty in understanding the different perspectives that go into the treatment of a medically difficult and ethically difficult case. So Lucy was a 12-year-old spayed female St. Bernard who presented to us for GDV. On initial presentation, she was shocky but resuscitated well. We did some pre-op chest films and had a heart-to-heart with the clients about what to expect with going forward with surgery. She was an elderly St. Bernard and already had some mobility issues and difficulty standing on her own, and we were concerned that surgery might set her back significantly. They elected to go forward with surgery, and she actually came through surgery well, and her initial recovery was smooth. However, she developed aspiration pneumonia.
So she had her pre-op films, which didn't show any pneumonia, any abnormalities, but she developed aspiration pneumonia post-op. And she really struggled with her pneumonia. We didn't need to ventilate her, but she was very much oxygen dependent and unable to rise at all. So she required a lot of very intensive nursing care. And remember, she was a St. Bernard, so she was a very large, heavy dog. She was also very uncooperative. She was very sensitive about being handled in any way, either to help her to rise, or change her recumbency, or to do any of the normal nursing care tasks that we have. So she had a hard recovery from her pneumonia, and she really just failed to rally. So during this time, one of my residents was the primary doctor on the case, and she had some very open conversations with the family about goals for Lucy and what to realistically expect in terms of her chances of recovery, and whether they were prepared to deal with her mobility issues in the long term. And just to paint a little bit of a picture, her family was elderly. So she belonged to an elderly couple. The male owner was a retired human physician, and he was a cardiothoracic surgeon. So came with quite a bit of medical expertise. But as we came to know them better, we found out he was suffering from dementia. And that came into play with some of the conversations once their children became involved. And started to voice their opinions on Lucy's care. So there was already some family dynamics that made this case a little bit more complex. And then medically, as we continued to care for Lucy, she developed pleural effusion. And we couldn't figure out why. We talked with the family about how aggressive to be with diagnostics, and they ultimately elected to go forward with a CT scan where we diagnosed a lung lobe torsion, but couldn't find any underlying pathology that would have caused the pleural effusion or the lung lobe torsion. So again, my resident spoke with the family about next steps, and if they wanted to continue treatment for her, that we needed to fix the lung lobe torsion, remove that lung lobe. And she had a very frank conversation with them. I think at that point some tension started to develop between our nursing staff and our doctor staff, and that the nursing staff wasn't present for the conversations that were happening with this family and didn't really have the perspective to know that this family was hearing about what Lucy's experience was, and that the chances actually were very poor. So they started to develop this dynamic between our doctor staff and our nursing staff that was not very healthy. And then the family elected to go forward with thoracotomy, which we performed and took some biopsies at that time, removed the torus lung lobe, and she recovered okay. So she continued to have pleural effusion and was oxygen dependent, but was cardiovascularly stable. We diagnosed her with mesothelioma and expected, I think everyone in the hospital expected, that would be a stopping point for the family. But they actually requested that we transfer her care to a hospital that had an oncologist so that they could perform intracavitary chemotherapy for her. So we prepared her for transfer, and I think that the staff all did some mental somersaults to feel okay with that plan. And when the family came to visit her prior to transfer, they elected to have her euthanized rather than transfer her. So this all took course over about 3 weeks or so. So this was a very intense case that involved our care for a very long time, and our staff got very personally attached to Lucy and their family, and there was a lot of very complex emotion and ethical and moral dilemmas that this case brought up. So I wanted to find a way for us to talk about these types of issues in a productive, professional way. And so I went looking for wellness in veterinary medicine. So I kind of looked at all the resources that we talked about. And what I found were
were a lot of self-care tips, a lot of focus on self-care, do yoga, meditate, eat right, exercise, leave your work at work, lots of criticism about how terrible we are at taking care of ourselves, kind of some guilt-inducing language about how it's our responsibility to take care of ourselves, and if we're not taking care of ourselves, then we're failing our patients. I understand where that language comes from. We're people who maybe that's the push we need to take care of ourselves, but it's pretty judgy. And I think the other thing that really stood out to me is that these are all very self-focused, very isolated interventions. So putting all the responsibility on the person who is just in distress. So my resident who can't keep it together to get through a very difficult day because they are totally traumatized by this situation they've lived for almost a month are supposed to go home and eat right and exercise, and then everything's going to be okay. So this didn't sit well with me, and I started looking into what's out there in the human field to help support trainees, and that's how I stumbled onto Balint, which we'll talk about till I'm blue in the face soon. But I feel very strongly that our problems in veterinary medicine with burnout, compassion fatigue, all of the stress that we deal with are kind of part of our career, and we have a responsibility as coworkers, as leadership, to try and create an environment that lessens these stressors, and to take ownership of helping people to cope with the stresses that we're imposing on them in our day-to-day practice. So our field is a field that is unlike any other. I think as employers, as leaders, we have a real responsibility to try and look after our people that we're basically putting in the combat zone, the emotional combat zone. So I wanted to talk a little bit about ways that institutions can support their employees, their colleagues. And when I say institutional support, it doesn't have to be a financial investment. It doesn't have to be anything super formal. Something as simple as debriefing about difficult cases after a CPR, even at the end of each day, where you just talk about what cases troubled you that day, can be huge in terms of normalizing the fact that we all actually are emotionally impacted by our patients. We don't have to squash it down, turn it off at the end of the day like good little veterinarians and pretend it never happened. Acknowledging the impact goes a really long way towards having a healthier approach to dealing with the stresses that we do. So a lot of general practices will have an end of day list or an end of day procedure. You close out the drawer, you clean every room, you mop. This could be something that you just work into your end of day procedures, where you say, okay, does anybody have a case that just troubled them? Did anyone have an interaction that is just sticking with them? Let's talk about it, and let's just let you air what's bothering you. You don't have to solve problems. It's just a way to actually bring them up, kind of give each other a little bit of compassion, and normalize the experience. If you have a really severe incident or a very discrete incident, one of the things that's very interesting to me is in firefighting brigades or in police units, when there's a shooting or a death or just a traumatizing experience, there's something called a critical incident response, which many if not most institutions will roll out. And that's where there's a professionally trained, usually a psychologist or psychiatrist, who has a very soon after the event debriefing with all of the involved parties. And that debriefing, that critical incident response, is really a touch point to then translate that into other supportive services that people might need. So this is something where you would need to hire an outside professional, unless you happen to be lucky enough to have someone in your practice. But if you have an incredibly traumatizing event, so say that you had an accidental death in your practice, that's horribly traumatizing to your colleagues. This is something where you can bring someone in for kind of a one-off, deal with the situation, and get people help and get them the resources they need very quickly. And if you Google critical incident response, you can find a list of trained professionals. Other things that you can do are support groups, and they can be unstructured, very loosely structured, so you can have just a peer-led support group. And so that could be something that you hold at your practice. It could be something a bunch of practices come together and do. It could be an informal going out for beers after work every third Friday or something like that. Or you can go a more formal route and have a professional lead that support group. In support groups, you can sometimes have the group turn in a negative fashion. So if you do have a peer-led support group and you feel like you're getting more negative than positive out of it, I would encourage you to hire an outside professional to come help you lead. And then structured support groups, there are, I am sure, thousands of ways to structure a support group. What I became very interested in was the Balint procedure. So Balint is a very structured examination of the human-animal bond, your interactions with the client, and the client's relationship with their pet. So this is all a procedure that I'm extrapolating from human medicine, but it's a way to, in almost a clinical way, look at the emotional content of the interactions that we have in a way that has structure that kind of makes it a little bit lower of a barrier of entry for people like us who might be a little more medically minded, prone towards structure. So I'm curious as to whether anyone out in practice actually has some sort of way to address difficult cases in a structured way. So I'm glad to hear. Yes. That's fantastic. So I think a lot of you guys are going to have regular meetings. This would be something where you can integrate that into your meeting. Not sure. So I would suggest that any of you who feel like your practice could benefit from this, talk with your leadership. If you are your leadership, think about ways that you can integrate it into just what's normal in your practice. Open communication. That is fantastic. All right, I'm going to move right along because I've got a 10-minute warning. And I wanted to talk to you guys a little bit about the Balint method. So I have definitely a reason why I'm here and giving this talk is that we're looking to start a Portland area Balint group for veterinary professionals. And I wanted to talk you through what that would look like to hopefully try and drum up some participation. So the Balint method is a structured group exploration of the provider-patient relationship. So what happens is one individual has some case that is bothering them for some reason. A lot of times we'll talk about it as the rock in your shoe. It's just the burden that you're carrying along. And you take that case and you describe that case and you hand it over to a group. And that group then starts to grapple with that case for you. And there are three focuses. So the work of Balint is to explore the patient perspective, the provider perspective, and the relationship between the two. So for veterinary medicine, we kind of stretch that patient perspective to include the client perspective. There are rules of respect and absolute confidentiality. So we are talking about cases that are troubling to us where maybe we're not that proud of our own behavior or how we interacted or the emotional response that we had to a client or a patient. So absolute confidentiality and respect to the presenter. One of the ground rules is that we assume that everyone is a competent professional. Medicine has really no role in this discussion because we presume that you did your medicine correctly. So that is a given. And there is no advice giving. We are not trying to fix a problem. We're not trying to tell someone how they could have avoided this problem. We are just there to explore the problem with the person who brings the case. So the benefits of Balint are that the presenter gets to hand over that burden to a group of people to really carry that burden and think through all of those well-tread paths that your mind is just stuck in, and try and open those up and unmask our reflexes and assumptions that we have. There's actually some evidence that Balint might help to kind of inoculate people against implicit bias, which is important for all of us, but a hot topic in human medicine. It relieves isolation and it reveals a common experience. So when we come together to talk about our cases, I think I was shocked when I participated in Balint groups with MDs at how incredibly similar our struggles are. So the same types of issues we grapple with, are kind of human issues, and anyone who's providing care for another kind of encounters the same type of roadblocks. It exercises the empathy muscle. So I know that's a little cheesy to say, but you basically practice empathy in a really safe place. And that means that you get better at giving empathy and better at still maintaining that empathy in a healthy way and respecting your own boundaries. The open-ended format teaches divergent imaginative thinking, which teaches the skill of tolerating ambiguity. So if you guys are anything like me, I like my cases wrapped up and tied with a little bow at the end because I have diagnosed them and treated them for exactly the thing that's wrong with them. But I think we all know that in reality, we're sometimes trying to shoehorn, a lot of different symptoms or a lot of different problems into a nice pat diagnosis. And we know that they don't always fit, they don't always read the book. And it's kind of scary to think that I might be wrong. I might be giving them this diagnosis and not entertaining all of the different possibilities. So even though this is a very non-medical practice, it teaches you skills that are important for clinical reasoning. And that's one of the things that is a core focus, especially when human residents are training. So these are some slides that I'm going to go through quickly that are actually provided by the American Balint Society. These are all based on how Balint works in the human medical field. So they start with defining what Balint group isn't. So Balint is not psychotherapy. It's not an encounter group. It's not a case consultation group where you talk about medical cases. It's not an M&M conference. It's not a topic discussion group with didactic rounds. And it's not really a personal or professional development group, even though you get personal and professional development out of this group. It is not prescriptive, didactic, or advice giving. So ideally, you want to have a group, and I am hopefully describing a bunch of people in the room right now. So ideally, you want a group who can attend on a regular basis. There are 2 leaders. You focus on the doctor-patient relationship, and you use the power of the group to really share an experience and expand from one focus to many focuses. And the preference is for an ongoing case, and we examine the less conscious aspects of the relationship. So the ground rules are confidentiality, respect, and turn taking, giving everyone a chance to speak. ownership of your thoughts and your feelings, and avoiding giving advice. So this is how it all goes down. So there are two leaders, usually situated at the opposite sides of a circle. And the leader opens the session calling for a case. So the leader will just say, who's got a case? And we wait for someone to speak up. So what's a case? What's a Balint case? So the presentations are spontaneous. People should not be planning ahead to present a case unless they've just got in their head, oh my God, I've got to Balint this case. Ideally, they're patients we have ongoing relationships with, patients we're conflicted or feel strongly about, patients that we feel unfinished over, who we lose sleep over, and just patients that bubble up in the moment. If you're sitting around in dead silence, no one has a case, and someone says, well, I kind of have a case, but it's not really a real case, that's a real case. So anything that's coming to your conscious mind means that there's fodder there to explore. So the presenter speaks up, says, I do, and then they present the case. So generally that's a signalment and a very brief medical summary. So this would be, Angela is a 79-year-old blind woman with myocardial infarction, and I had this interaction with her and her family, and this is what I'm struggling with. And then that presenter stays in the group, and the leader calls for any clarifying questions. So these are informational, concrete questions only. Does Angela have any children? Are there complicating factors in her medical case? These are not questions that are focused on, well, did you get really angry when she said that? Or starting to do the work of the actual group. And then we actually have the presenter push back, either metaphorically or physically, remove themselves from the circle to some degree, and we protect them. So that presenter now gets to sit back and listen while the rest of the group takes on the work of examining this case. And so the group starts working, and so in this case, the first participant says, I imagine Angela to be, and they put themselves in the place of the patient. And we go back and forth, patient, client. So the doctor, so if I were in the place of the provider in this relationship, I would feel threatened by the fact that she wanted a second opinion, things like that. And then really spontaneous, kind of imaginative thinking is encouraged. So an image that pops into your mind, some metaphors that might come into play. So I was in a presentation where someone brought up a depressed patient and happened to mention rain, and that kind of metaphor of rain and crying was an interesting thing to kind of ruminate on as a group, and just what that meant in that context. And talking about the relationship. So this provider-patient relationship, does it mirror other types of relationships that we see? What does this patient need from this provider? What does this provider need from the patient? So the function of the group members is to explore that relationship, to look inward, be imaginative and creative, and look for the less conscious aspects. So things that the presenter might not be aware of. And it is okay and encouraged to be wrong. All we're doing is exploring possibilities. The relationship between what we're talking about in the group and reality can be pretty darn tenuous. And we want to attend to and share any thoughts, images, fantasies, associations, hypotheses that kind of bubble up in our mind as we're talking about the case. You want to differentiate your own experience from the presenters. So you don't want to say, oh, I had this patient who was exactly like this, and this is what I did. That's not really a helpful exercise in this setting. And we want to further empathic understanding. So try to understand truly where each individual is coming from. So the function of the group is to provide a safe place for emotional reflection on troubling cases, to help the presenter consider other understandings about the case. So we tend to just retread the same pathway until it's a deep groove, and that's really all that we can see. opening it up to other individuals with other experiences can kind of help us to see the situation differently. It lets us look at our blind spots and assumptions, and it helps the team members feel less isolated, less shame, and more open to learning, even in this emotionally charged situation that they're in, that there's still the opportunity there to learn and grow. So the benefits for the clinicians who are participating are that you do get to explore these situations, which there's really not a forum for otherwise, to refine those patient clinician relationship skills. So how you're interacting with your clients, by participating in this practice, you're learning to entertain other perspectives in addition to your own, to hear and learn from others' cases, to connect with others and kind of feel the power of a group. So a group of people who are having experiences just like yours. And it helps us reconnect with what actually matters about our work. So when you're taking these patients home with you, you're not actually taking them home because you're really pissed off at that client. You're taking them home because they're troubling to you, they're bothering you, they're making you wonder, where is my role in this that's productive? So it helps us to reconnect with our purpose in work. And that helps us to avoid burnout, increasing engagement, and build up resilience to where you can say, okay, I'm having this really challenging interaction right now, but I know there are other perspectives that I'm probably not even thinking of. I'm going to reserve judgment and maybe not react as dramatically or in a knee-jerk fashion. So Balint in veterinary medicine is kind of in its infancy. There are some people who have started up groups kind of isolated. There's not really any way to do Balint in veterinary medicine that's recognized as the right way. So we are going to start a Balint group. I have a credentialed Balint leader who leads a group out at OHSU, who is going to join me as a co-leader to start a veterinary Balint group. This is meant to be open to any veterinary professional in the Portland area. I say in the Portland area because you'd have to come here. Right now we're still trying to sort out the best location, and that's going to be partly dependent on the group size. So if we have a group size that works for us, we're hoping to have that in the hospital. And once we have a list of interested parties, we're going to send out a poll so that we can schedule a time that's going to work best for the most people. And if I have a ton of interest, we might have more than one group. When we first start out, my plan is to have it just be open enrollment for people to come on in and see what it's like. Eventually, we're going to be asking for a commitment to continue to attend so that we can build some group cohesion. And at that point, we'll kind of limit to just certain times when we enroll new people. So if this really takes off, we can have multiple groups that are starting at different times of the year. So if you have any interest at all, we have some cards up at the table, or you can go online under the Contact Us button. There should be a drop-down menu that says interest in Balint. If you don't find it, just send an email. It all kind of goes to the same place anyway. And your name will get to me, and we'll put you on our list.